Hello, hello. Thank you very much for being here with us today. My name is Dr. Julio Meza, and we are going to be speaking of a topic that is really dear to me, especially because it's something that I deal with in a daily basis, more than anything, what the uses of this medication has. And today we're going to speak in regards to the role of naltrexone in alcohol use disorder and also the uses that it can have. Okay, it has been proven to be quite of a versatile medication in the past few years. The first thing, definitely, we have to delineate the objectives. The first one is that we are to understand the mechanism by which naltrexone works in treating alcohol use disorder, and especially its mechanism around receptors in which attaches and explains the pharmaceutical efficacy that the medication has. Then also we're going to speak in regards to the efficacy and safety that medication has as well, right? Is it easy to use? Is it something that has potential harmful side effects to pay attention to? And also some broader applications and other things to take into account when it comes to using naltrexone in a broader population in a larger scale. So what is naltrexone? I know that a lot of us were pretty familiar with the term naloxone, okay, which is a similar molecule to this one right here, okay? And in reality, naltrexone and naloxone, both of them, they're opioid blockers. What is the main difference in between one versus the other one? The difference lies on the length of therapeutic benefit that we receive from one versus the other one. Naloxone, commonly known for the treatment of opioid overdoses, is something that is really short acting compared to naltrexone, that is a longer acting medication, whether it's in its oral form, but especially noticeable in its injectable form. What does it do? So naltrexone is a opioid blocker at the mu, also at the kappa and at the delta opioid receptor. So what it's going to do pretty much is going to attach to that receptor, and it will not allow any other opioid, whether this one is internally produced or exogenous, to act on the opioid receptor, by which is going to be really effective, especially on blocking effects of pain medications, for example, okay? Because in order to override the effects of naltrexone, we need to find an opioid that has a a better affinity for the receptor compared to naltrexone, which we don't have too many of those. Okay, we can count on pretty much in the in the fingers of our hand 3 medications that can override the effects of naltrexone. One of them is fentanyl, another one is dilaudid, and another one is going to be buprenorphine. Outside of that, the majority of the opioids out there in the market, they will be unable to displace naltrexone from its position on the opioid receptor, for which is a really versatile medication in that regard. Now, it's really interesting because as time has gone on, right, definitely we have known that the effect on the opioid receptor, albeit its main way of creating a therapeutic effect, is not the only way in which naltrexone actually acts, okay? Another thing that we can see as well is that it can affect not just the opioid receptors on the neuron, but also when it comes to the microglia in our brain, is going to affect some of the receptors externally located on the microglia. The name of this receptor is toll-like receptor type 4. And what does it do? So what we have noticed through research is that by blocking these receptors as well, we're going to decrease the number of an amount of cytokines that the microglia can actually produce. By doing so, it's going to also decrease some specific cytokines that are going to promote inflammation, which is the reason for which some of the new uses of naltrexone is not just related at this point in time only with substance use disorders, but something more specific, such as pain. And even we can speak about weight loss as well. Okay, so naltrexone, definitely their uses are expanding based on the fact that we know that it's not just going to affect the opioid receptors themselves, but also is going to have some effects on some of the receptors, and which is going to help to modulate pain on some individuals, and in some of us even decrease appetite. So due to that is that definitely the uses of naltrexone are increasing, and we see more and more in the market being mentioned, okay? Now, I want to make clear as well that despite all these new uses, especially the branded formulations out there in the market, they still have only 2 FDA approved uses. Okay, one is going to be for alcohol use disorder, and another one for opioid use disorder. There are some combination of medications that they have a different approval, but definitely is in the combined form with whether it's topiramate or with Wellbutrin, in which we can find that they can have some other effects on people. Okay, but right now, naltrexone itself, as a standalone medication, definitely has only approval for alcohol use disorder and opioid use disorder as well, due to the mechanism of the blockade of the receptor. Now, you may ask yourself, but what does have to do the use of alcohol with the use of opioids? How come this medication that we use to curb the cravings for opioids is going to be utilized for the craving of alcohol? For opioids, it makes sense. I mean, it's an opioid blocker, just like naloxone, as we mentioned, just longer acting, okay? But it definitely makes sense that it will be a medication easily utilized in market, and it has feasible ways in which it works for opioid use disorder. But how about alcohol, which is the main, is one of the actually mainstay treatments at this point in time for alcohol use disorder specifically. So interestingly though, despite alcohol not having specific receptors in our brain, it's going to act in multiple aspects, okay? One of the ways in which alcohol is going to act definitely is by pretty much increasing the effects of GABA in our brain, and also is going to be a NDMA antagonist, okay, decreasing the effect of glutamate. Now, in order to promote such effect, okay, another thing that alcohol is going to do is that it's going to attach to the same receptors that opioids do, to all those mu, delta, and even kappa receptors. So by alcohol having the capacity to stimulate these receptors, we're going to see that it's going to exert the euphoric effect that alcohol produces. Some people, they even call it the high of alcohol, right? That sense of euphoria, a little bit more of happiness, okay? And definitely the way in which affects our behavior to behave a little bit more silly and so forth, okay? That is mediated through the mu receptors, okay? The more we stimulate these receptors, there will be more dopamine being released, and the buildup of dopamine and definitely the release of dopamine with higher frequencies is going to allow to that pleasurable effect that some of us will have when having intake of alcoholic beverages. So by that premise, right, if we use naltrexone, it's going to block the opioid receptor. Alcohol will attach to the rest of receptors that can attach to, but will be unable to exert its effects on the opioid receptor itself. What implication does that have therapeutically? One is going to decrease the urge of drinking, because we just feel like, okay, that wasn't a fun drink. Okay, it's definitely something I didn't enjoy at all, right? And then it's going to also decrease heavy drinking days, and also is going to occasionally, on some of us, even promote abstinence, okay? Now, let's not forget, as I mentioned before, naltrexone is going to act only and only in one type of receptor. It's not going to act on every single receptor that alcohol has the capacity to attach to. Why do I mention this? Because the motor effects that alcohol can produce, they will be present if we drink on top of someone who has taken naltrexone. We will not have the euphoria or those enjoyable effects of alcohol that some people tend to like. We will not have that situation in which once the first drink comes in, the switch goes off and we just keep on drinking. That effect, for the most part, goes away, okay? But definitely the motor effects, the diuretic effects of alcohol, they still will be present, okay? Why do I like to mention this? Because a person on naltrexone can get a DUI, okay? And definitely it's going to be something pretty upsetting, because definitely there was no enjoyment at all. And now they're facing actually facing a ticket and a conviction due to a DUI in this case. Why is that? Because the motor function will be affected. It's interesting when I have conversations with some of my patients who are taking naltrexone, in which for X, Y, or Z reason, one day there was this decision to test the medication to see how good it works. And they tell me, hey, Dr. Meza, I did go out, I had a couple of drinks on X day, okay? And let me tell you, to me, that experience was weird, okay? And, weird is not a symptom, so I try to have them define for me what they mean by I felt weird, okay? And most of the description that I have found is that they felt like they were not in full control of their body, which it makes sense, right? So if you're someone who's taking naltrexone, whose opioid receptors will not be affected by alcohol, you're for the most part conscious. You definitely know what's going on. Okay, you see your surroundings, you see what definitely is happening, but definitely your motor effects. The motor effects of alcohol still will be present. So some occasions you might be dropping things. Okay, you might have a little bit of numbness because of depending on the amount of alcohol. So it's noticeable to you, right? Compared to when we're euphoric and inebriated, right? It's one of those things in which is we drop a pen, we feel like, that was so funny, okay, and we pick it up, right? When we are on naltrexone, definitely all that euphoria goes away, but you still can feel like there is something off about the way in which your arms and legs move, okay? So definitely it's always important to remember individuals not to drink on top of naltrexone. And if that event was to occur, whether it's conscious or unconscious, okay, to make sure that they do not try to drive, okay? Because the potential for a accident or in the lesser extent, so definitely we will see, right, that it's definitely not advisable for us to drink on top of naltrexone because definitely we're going to have the motor impairment and definitely it's not going to be a pleasurable thing. Added to that, I have had a couple of patients that try to challenge to see how much you can go beyond the effect of naltrexone. Highly unrecommended. I do not recommend anyone to try this, not even as a social experiment, because both of them actually ended up in the hospital because of the amount of alcohol that needed to be taken in order to override the effect. So definitely we had to admit them because they were severely mentally depressed at that point from the standpoint of how inebriated they were. So they had to drink way too much, affecting their respiratory status and mental status. So I definitely discourage anyone who attempts to utilize alcohol to challenge how much we can go on drinking in order to see the strength of the medication itself. So definitely not a good recommendation. Now, definitely we have that. Nowadays, we have 4 medications, or well, 3 FDA-approved medications for alcohol use disorder, and we have one that we use of label quite efficiently, and actually 2 of them that are really efficient. But always when I see my patients, I give them the pros and cons of one medication versus the other one, okay? It's my duty to help them to make the best informed decision they can, right? Even though nowadays, hands down, naltrexone tends to have the best results out of the 3, definitely it's a good thing to share with them what else is on the market, right? So on the market, we have that the FDA has 3 medications approved for alcohol use disorders, one of them being naltrexone. The second one is going to be acamprosate that we see on the right column. And then on the middle, we have disulfiram, okay? Each one of them is going to have a different way to act. None of them share the mechanism of action one to the other. So that's why, to an extent, it's somewhat versatile because even side effect wise, they're totally different. And even from the standpoint of potential liver or kidney impairment as well, the 3 of them behave differently. As I mentioned before, naltrexone is going to be an opioid receptor antagonist and is going to block the euphoric effects of alcohol, okay? Pretty much makes alcohol to feel boring, okay? It blocks the urges as well, okay? Which are the main things that we're looking for. One of the patients, definitely one, they explained it to me really nicely. He told me, you know what, Dr. Meza, let me explain you better compared to what your textbook says on what naltrexone feels like. Naltrexone pretty much feels like, you know, when you're not on naltrexone, it's like if you pass by that burger joint at noon when you're completely hungry and you just get a little bit of the smell of that hamburger, okay, and you go in and you want to have as many hamburgers as you can until you get completely filled. When you're on naltrexone, is the equivalent that you still love that burger joint, that you do like love those hamburgers, but it's like if you were to pass by that spot around like 4 p.m. and you're completely full. Okay, you just say like, it's nice, I like them, but I don't feel like actually eating a hamburger right now. That's how they have explained to me that it feels like to be on naltrexone. You just don't have that desire to drink alcohol. Disulfiram, on the other hand, is going to inhibit the aldehyde dehydrogenase, okay, causing definitely inhibition of the metabolic pathway of some metabolites from alcohol, which is going to lead to multiple symptoms if we were to drink on top of disulfiram. Okay, for the most part, we're going to have nausea, stomach cramping, occasionally diarrhea, flushing, this sensation of hot spells. So definitely it's not really comfortable to drink on top of disulfiram, and is the reason for which some people use it to try to avoid the use of alcohol when taking disulfiram by just pretty much making you feel really unpleasant. And then acamprosate is going to modulate glutaminergic system to reduce alcohol cravings, okay? This goes more to the other receptors in which alcohol can act, right? As I mentioned before, alcohol is GABAergic, but it's going to be glutaminergic antagonist. It's an NDMA antagonist. So acamprosate is going to try to modulate that in order to have less of the effect over the GABAergic system, and also is going to enhance the glutaminergic effects that our brain is supposed to have compared to when it's inhibited by alcohol. The dosage of naltrexone is 50 milligrams daily. There are some occasions in which we might need to increase it a little bit, or 380 milligrams intramuscular per month. In case of disulfiram, it ranges in between 250 and 500 milligrams orally daily. And in case of acamprosate, it's going to be 666 milligrams 3 times a day, okay, which is occasionally one of the most inconvenient things that my patients voice to me is how many times per day you have to take acamprosate. It's 3 times a day versus the other two medications, which is once daily. And another thing that I have to mention, right? Some of us definitely we have a religion as a really big part of our life. I had someone who actually mentioned to me that she would not like to take acamprosate because of the depicted number on the dosage, right? The whole 666 thing didn't think it was pleasant, so definitely kind of pushed it away, okay? But that was a really unique case. How effective are these medications? Naltrexone definitely is effective on reduced relapse rates and heavy drinking days, meaning that even on someone who's actively drinking, we can start to see benefits from naltrexone. Most difficult to be noticed, though, on patients who have other mental health conditions who are not being treated, like people who have depression or anxiety, right? We might not see this effect as quickly as we wish. Disulfiram is going to be effective on patients who are highly motivated to avoid alcohol on special circumstances, okay? For example, if I had an uncle who knows how to convince me to drink alcohol, and maybe I'm just trying to refrain from such usage, right? I can take my disulfiram, okay, go to visit my uncle. He's going to try his best to engage me in the intake of alcohol, but I might be able to say, hey, like if I'll get really sick and potentially throw up on your floors, right? If you give me alcohol. So some occasions that'll do the trick, and it's the truth. That's highly likely to occur. And acamprosate is going to be effective in maintaining abstinence. But as you can see, it says there, particularly after detoxification. Now, when it comes to acamprosate, we do know that the trials showed effectiveness of acamprosate 5 to 7 days after the last intake of alcohol. We do not have any data to promote that on someone who's actively drinking, acamprosate is going to have a really huge value on decreasing those drinking days or the amount of alcohol that is being utilized as well. Which ones are the contraindications for each one of them? The contraindication specifically for naltrexone is going to be severe liver disease, okay? And we're speaking of people with liver failure, which is decompensated. In my case, when I see patients in our clinic or even in the hospital, right, we're speaking of Child-Pugh scoring of Child-Pugh C, okay? Child-Pugh C or meaning 10 points or above, okay? Another thing is any patient who is dependent on opioids, someone who has been receiving pain medications consistently, okay? As we mentioned before, it's an opioid antagonist. So if we give these medication to someone who is dependent on opioids, it's highly likely we're going to throw them into withdrawal. The key word in this case is the fact that they're dependent on opioids. For example, let's say that Julio Meza goes and gets some dental work performed today, and someone gives me a couple of hydrocodone for the next 2 days, but I don't use or I don't take any type of pain medications consistently. These are going to be my only 2 days in which I'm going to take these ones because of the amount of dental work that I had. I take my hydrocortisone, I finish my treatment for 2 days only, I feel better, okay? And then I want to engage on receiving naltrexone because I have issues with my intake of alcohol. I can definitely receive whether it's the formulation or the injectable formulation. Why is that? I'm not dependent on, I took it today for my having patient dependency is going to lead to withdrawal. What is the amount of time in which we need to take opioids in order to become dependent on it? Depending on the textbook that you read, it might be anything from 10 to 14 days, okay? So on someone who incidentally took an opioid or just as prescribed for a few days, okay, definitely is not a concern what we see right there. If it's someone who's dependent, definitely they have to be removed from the opioids and do not start naltrexone until 5 to 7 days. There are new studies that have shown actually quicker initiation of naltrexone or on patients who are dependent on opioids, but definitely need a more protocolized way to do it as well. In case of sulfiram, definitely not recommended on people with heart disease, psychosis, or pregnancy. As well, another thing to take into account is patients with liver disease and post-transplant patients. Prostate is going to be in patients with severe renal impairment when we are not to utilize a camprosate. What are the monitoring requirements that we may need for our patient population? If we have naltrexone liver function test, at least 3 to 6 months, as long as they are on naltrexone. Okay, we know that there is potential elevation of AST, ALT with naltrexone, but it tends to subside spontaneously. There is no need to discontinue the medication. Back in the days, the recommendation, the black box warning actually existed to say to discontinue naltrexone if that was to occur. Nowadays, we know that whether the naltrexone is continued or discontinued, the liver function tests are to improve if thought to be only and only due to the naltrexone usage. Sulfiram, as well important to monitor liver function test as well, similar frequency, as well to make sure that we are doing pregnancy tests on those patients in which they are on age in which they're able to conceive. When it comes to the effects of disulfiram on liver function tests, definitely this one makes me a bit more concerned. And this is going to occur on patients who take it daily. Patients who take it sporadically is highly unlikely. I'm yet to even see a case reported in which that's the reason for which disulfiram was removed, okay? This is going to happen on patients in which they're taking disulfiram consistently for several weeks. And when the hepatotoxic effects of disulfiram occur, they tend to be pretty severe. We're speaking of ASTs, ALTs on the levels of thousands. So it's really noticeable, it's scary, and definitely one of those situations for which I'm not a big fan of the usage of daily disulfiram without having a specific end date. In case of a camprosate, it's important to assess for renal function, and definitely is not thought to be that a camprosate is the one leading to the renal dysfunction more than anything on those patients in which are more predisposed to to renal dysfunction. Definitely it's important to monitor them, right? Patients with history of diabetes, patients with diagnosis of hypertension, or any other type of heart condition, definitely it's important to pay attention when they are on a camprosate. But a camprosate itself hasn't been seen to be nephrotoxic per se. What's the dose of naltrexone I mentioned before? Is usually 50 milligrams per day. There are some trials that have shown that maybe a dose increase up to 83 milligrams can be effective. Now, really difficult to cut pieces of a tablet to make 83 milligrams. So I'll be honest to you, when we have to increase the dose of naltrexone, we would actually do it in a fashion in which we double the dose to up to 100 milligrams per day. Highly recommended to start by half of the regular dose per day. Reason being is the side effects that this can lead. And as we can see on this table, right, the side effects of naltrexone include nausea, headache, dizziness, fatigue, okay, especially those four. And when they occur, they're quite uncomfortable. And most of the time, they're dose related on people who have not adapted yet to the medication. So it's a good idea to start at a lower dose. And after 4 days of taking your medication and you see that these effects are not occurring, definitely you can bump it up to the 50 milligrams. Really rare, there is about 1.5% of patient population who will definitely have these effects consistently with the medication, in which we need to look for an alternative, but it's not a frequent thing, okay? Reason being as well, for which I'm still a big proponent to try the oral medication first before engaging into the injectable formulation, unless we're in a dire situation in which the patient knows has been effective in the past. They might be discharged from the hospital, or maybe they won't be able to come and see me soon, in which we can just proceed with the injection. But otherwise, it's good to do a trial with oral for a few days, not necessarily weeks, okay? And then we can start the injectable naltrexone. What is the injectable naltrexone? As we can see, there is the extended release formulation of it. Naltrexone is actually suspended in little microspheres for this formulation, and it is injected a total of 380 milligrams every 4 weeks. Is even less likely to have side effects with the injectable formulation just because of the sheer dose itself is lower, okay? And definitely the effectiveness is quite well known. The reason for which the effect is so good when it comes to the injectable as well, especially comparing the difference in between dosing in between injectable and oral, is the amount needed to produce a therapeutic effect. It's well known that naltrexone needs to produce at least zero point 0.9 nanograms per deciliters of beta naltrexone in order to be effective for both alcohol and opioids. With the oral tablet, because of the metabolism that the medication undergoes in the liver so quickly, we have to overshoot that dose by about fivefold. Okay, with the injection, because of sustained release, definitely we don't have to do such things. So why especially those side effects, which are those related, are less likely to occur with the injectable formulation compared to the oral. Definitely, it's really important to adhere to a prescribed regimen, especially when we're using it for opioids, which we're going to have a little conversation later as well. Side effects, we mentioned them already. Okay. Considerations, as I mentioned before, especially on those patients with liver dysfunction, severe decompensation, child pussy is one of those contraindications that is better not to give at that point in time. And definitely not suitable on patients who are dependent on opioids, as I mentioned before. So if someone is taking opioids, naltrexone will not be the medication we're going to reach for in this case. And let me make sure that also I clarify the misnomer, okay? Some occasions I have questions in regards to tramadol or tapentadol not being opioids, and if naltrexone can be a suitable option for those patients. In reality, it's not. Anything that is that acts as a mu agonist, even if it's not an opioid itself, such as tramadol and tapentadol, is ideal not to have naltrexone being our first line of defense when it comes to alcohol. Now, definitely we know it's affected on opioid use disorder. The fact that it's going to attach to the opioid receptor says it all, right? And definitely what it has been seen, right, is that is able to prevent relapse on the usage of opioids, okay? Highly recommended after the detoxification period has occurred. Now, there is a trial that was performed in Sweden that said specifically the third line of what I have in this slide, and is that there is a comparative effectiveness and efficacy when we compare naltrexone to methadone and buprenorphine. True, but it depends on the system. As of right now, especially as we see it in our current environment, naltrexone actually, even on the injectable formulation, is considered to be second line treatment for opioid use disorder. Right now, the main and primary lines are going to be definitely methadone and buprenorphine. Why? Because of effectiveness, definitely decrease on mortality as well, the decrease on re-engaging on usage of full mu agonists, and as well decrease in criminality. Now, you may ask, so why would I add such a line in this case? Okay, so the study, and the reason for which I did is because definitely these information exists out there. And I'm not saying that the study made in Sweden, definitely it is incorrect. Actually, it was seen that naltrexone, the long-acting injectable, was just as effective as methadone and buprenorphine. The caveats is that in these countries specifically, when this trial was made, the other two medications were given only and only as dispensed in a clinic. So people will have to go to a clinic in a daily basis, get their methadone dispense and buprenorphine dispense as well. Okay. The only outpatient therapeutic that they could receive was naltrexone injectable. So definitely more people were trying to engage with keeping a normal life by utilizing the naltrexone injectable at that point in time. The effects on cravings, they're not as immediate as there will be with methadone and buprenorphine. We do know that naltrexone can take for craving, especially curbing those craves, can take anything from 8 to 12 weeks from initiation. So they will have the benefit of the opioid blockade in the first few weeks. They just will not notice that effect on cravings to decrease as fast as it will be with buprenorphine, okay? But can we say that in the right setting, with the right stimuli, okay, can be as effective as methadone and buprenorphine? Highly likely, okay, as they proved it on this study. But as I mentioned before, it was the only outpatient option out there that you can be at home compared to the other two, in which you still can be at home, but you're going to be traveling to your site to receive the medication dispensed on a daily basis. So pretty much naltrexone didn't have those shackles attached to it specifically. And definitely is really suitable for patients motivated to maintain opioid abstinence. Just as I mentioned on the table in regards to alcohol, in which I mentioned that is ideal to wait anything from 7 to 10 days to initiate naltrexone. The same situation happens for opioid use disorders. So these are patients who, if they were dependent on an opioid, they will go through the process to remove all the opioid, go through the symptoms of withdrawal for a time span of a week. And then after that, they can receive naltrexone. Okay. There are even movies made about how difficult some occasions this task can be. Okay. Especially when the support is not there on how to go through all the different symptoms that opioid withdrawal can lead to. So it's not necessarily the most suitable idea for everyone, but we can use it. Okay, we still use it in our clinic as well. But as I mentioned before, it requires the right type of patient in the right environment, at least to do the initial portion. Now, besides substance use disorders in light of alcohol and opioids, are there any other uses that naltrexone can have? Yeah, definitely. There are some fair usage that we know as well out there. There are some other use disorders in which we might be able to use it, cocaine and methamphetamine. So for example, the ADAPT-2 trial, okay, performed at UCLA by a colleague of ours, really esteemed Dr. Shopta, pretty much it did show that methamphetamine use disorder seems to be something that naltrexone can help us with, okay? Naltrexone combined with high doses of bupropion, this showed decrease on the number of positive urine tests to methamphetamines in the weeks in which the trial was being run. So nowadays, we do use it with that intent. It does not have an FDA approved per se. Most of the patients in which I have been able to do it in my clinic outside of the ones on the trial are going to be patients who also have some history of alcohol use disorder as well, because of the approval required to obtain the medication, specifically the long-acting naltrexone, which is the one that was utilized in the trial. Do we have any way to say that the tablets will not work necessarily? I can't be so certain of that, but I do know that the trial did not do it with the oral formulation. It did it with the long-acting formulation. So I know the benefit that it can render, reason for which that's the way in which I use it at the moment in time. That might change depending if more trials are run with the oral formulation of naltrexone. Chronic pain management. Okay, actually, it's pretty funny. This past weekend, I was talking to one of my colleagues from palliative care around the potential beneficial effects that naltrexone has around chronic pain. When we look at the body of evidence, rheumatology actually has run really good tests around it in regards to the use of low dose naltrexone, especially for fibromyalgia. it seems to work at the level of those receptors that I mentioned at the beginning of the presentation, specifically when we look at naltrexone right here, how it kind of splits into pathways, right? The high dose is going to affect definitely the opioid pathway, producing opioid blockade. But when we're doing between 1 to 5 milligrams, more than anything, is going to reduce glial activation and decrease of cytokine production, especially pro-inflammatory cytokines. That's the premise by which these is proposed in which is going to work. So on patients with fibromyalgia, it's even considered to be a disease-modifying agent. Now, definitely to obtain this type of formulation, it has to go to a compounding pharmacy. So you won't find on the market the 1.5 or 3 milligram tablets. This is something that has to be ordered from a specific pharmacy that will manufacture the tablets for you, and in that way your patient can obtain it. The starting dose usually tends to be around 1.5 milligrams per day, and then you increase in a weekly basis to 3 or 4.5 milligrams. And definitely you should see a dose response to pain improvement on your patient, okay? It's not enough to produce blockade of the opioid receptors, as we saw on the slide before. So that's just something to pay attention, especially on those patients in which they also have an opioid use disorder. It will be a misnomer to say that definitely the low dose naltrexone will help with chronic pain and also protect against opioid use disorder. Definitely the doses, they're completely different, even if we were to use a long-acting injectable. Is there any evidence on the use of the long-acting injectable for chronic pain? None that I have seen, at least not on the research. Theoretically, it's a sound-minded way to think, okay, just because the dose of the injectable technically is lower, right? But let's not forget, when we take a low-dose naltrexone, definitely the amount of distribution and how much is absorbed, right, is going to be pretty different compared to the injectable formulation. So definitely I'm not going to cite anything that I haven't seen out there, but as of this moment, I haven't seen that long-acting naltrexone in the form of the injectable formulation has any benefit in pain. And right now, definitely there are some other investigational usage, such as in autoimmune diseases like multiple sclerosis and Crohn's disease. And pretty much the theory is the same one that we see for patients with chronic pain, especially around fibromyalgia, and is the decrease on the amount of the cytokines that we produce, the pro-inflammatory cytokines that we produce, and that will decrease these inflammatory processes that can affect some individuals with autoimmune diseases. Now, another usage that we have found, okay, is as well naltrexone for gambling disorder, okay? And it's because it's thought that just as it happened with alcohol and in several of these process addictions, as some people call them, okay, but especially in gambling, right? The pathway that is followed is really similar to what we see, as I mentioned before, with alcohol use disorder, which is a stimulation of the opioid receptor, increase on dopamine, and then pleasurable effects. So it's thought that naltrexone is going to help to block that pathway in a similar way as described in my previous slide, in which by having a blockade of the opioid receptors, we're going to decrease the rewarding effects of gambling. And in that way, we're going to reduce the urges and desires to actually gamble and continue in the same pathway, right? We've seen several studies at this moment. Definitely, there is no randomized controlled trial that has looked at these specifically. More than anything, we have case series, case reports as well, in which the urges and behaviors have decreased, specifically around gambling specifically, okay? Now, most of these studies as well, they have some confounding factors, okay? They may have some other type of substance use disorder occurring, especially alcohol, because as we know, right, and we've seen it in the casinos, right? When people are gambling, they get free drinks and all that, right? So it's thought as well that the ideal patient, as we can notice on the slide, right, it will be that individual in which the gambling disorder is co-occurring, especially with alcohol use disorder. And by treating the alcohol use disorder, having the patient more clear-minded to make their own decisions also might engage them to not continue on the pathway of gambling. So that's a theory as well. It's not FDA approved for gambling disorder, so that makes it more difficult to try by itself and stand alone compared to someone who also has a comorbid opioid use disorder or even alcohol use disorder, in which is you have an opportunity to obtain the medication from the insurance company, and in that way provide some benefit to some people that might engage on both alcohol usage and gambling as well. Okay. Other uses not mentioned here, some definitely has been seen that naltrexone can decrease about 5% of body weight in 6 months from the moment we start using it. That's why there are some specific brands out there in which there is a mixture of low-dose naltrexone plus bupropion as a weight loss medication. And as well, we have the use of naltrexone and topiramate with the same intent. Okay, so these combinations definitely have been seen to be not as effective as what we see nowadays with the GLP-1 inhibitors, but definitely they have a modest decrease in decreasing weight, okay? Which is another thing that is pretty enticing to some of my patients that come into clinic, right? That definitely we can help them with their alcohol usage. Added to that, the more likely medication, unless a major contraindication is happening, is going to likely decrease also their body weight. So some people definitely feel that that is an added benefit that otherwise wouldn't have received. And then, needless to say, right, the financial incentive. I mean, to some of us, alcohol has become a pretty big financial drain. Needless to say, gambling can be a big financial drain as well to our household. So by helping with those, definitely you see the financial gains. And needless to say as well, when it comes to the interpersonal relationships with the people that we love, right? Maybe we have individuals in our family who are really concerned on our behaviors by treating gambling disorder, maybe alcohol use disorder, opioid use disorder. Definitely we're going to help to regain that capacity to engage with our loved ones and to have that trust again that we might have lost due to our usage or our process behaviors as well. Definitely one of my favorite characters in all Greek mythology, and I'm a Greek mythology geek, is Hercules. He's awesome, and that's why I love some video games where he comes out just because he's great. And I really appreciate the time that you share with me today. Here is my name and definitely my personal cell phone number and my UCLA email if you want to contact me. And thank you for your time.
Dr. Meza, did you share your secret code?
Yeah.
Oh, perfect. Perfect. Thank you.
Yeah.
Okay, I will stop it now. Thank you.
Yeah, I did it just before the what's the name? The
Perfect.
thank you slide. Yeah.
Thank you.